I'm doing the Peds surgical airway. This came up because the way we do the pediatric airway has changed a little bit. So what do we do now, or what's something that we, if you can't intubate a kid, what's the ultimate step? Or before I'm going to tell you what we do now. Does anyone remember?
It used to be jet ventilation.
Jet insufflation. So essentially you're putting a needle through the trachea and then hooking it up to some tubing and then just like blasting it and hoping for the best. I was never super happy with it because it doesn't get your SATs very high. Like, you're still only going to have SATs in the 80s. And I've also recently discovered that the failure rate is very high of getting the tube in. They quote like a 50% failure rate, and the reason is that when you're pushing down on the tube, the needle into the tube, the pressure that you need to push that tube in is greater than the pressure to compress the trachea of the kid, and so then the needle ends up through the trachea 50% of the time. And on top of that, the complication rate of jet insufflation is quoted at 30 to 40%. So not only does the kid like explode like a Michelin man, but you have very high pressure to push that air through a tiny little tube, and so that often causes pneumothorax. So recently in the EM blog world, they've been talking about these surgical airways, much like what we do in an adult, with just a slight variation. And it seems that the success rate for that is much higher. So I hope none of us ever have to do this, but to kind of get us up to where the now standard is going to be, we're going to talk about how to do a surgical airway for a little kid. So if everyone just wants to come up here, I'll just sort of sit just so people can kind of see more easily. But yeah, so the idea with a surgical airway for a kid is very similar to what we do with an adult. So you guys know that when we have an adult with no airway, they talk about the finger bougie tube technique with an adult surgical airway. This essentially slight variation with a kid is that rather than making a horizontal incision, they recommend making a vertical incision through the trachea. So the reason for that is that, again, because these airways are so tiny, they speculate that if you make a horizontal incision, actually it's not just speculation, it's based on animal models. If you make a horizontal incision like you would in an adult, the chance of you transecting through the entire trachea is very high. So because of that, they suggest making a vertical incision through the trachea, and you'll cut through 1 or 2 tracheal rings, and then the steps will be the same, bougie and tube. So just to kind of go through it step by step, I'll just start by mentioning that this is probably better as a 2-person technique, so it's great that the nurses are here watching, because although the physicians will likely be doing the incision, it's very helpful to have an extra set of hands to retract the skin to be able to see the really tiny airway. These are probably not the best. We are going to purchase some right angle retractors. They're a bit safer. These look fairly innocuous, but they can potentially cause damage to this very small sensitive airway, which has vessels on either side of it. So I've brought these just to be able to kind of demonstrate what it will look like with 2 people, but we are going to get some right angle retractors for when we hopefully we never have to do it. But anyway, so one of the things just to remember is a little bit of neck extension just for positioning, just to sort of accentuate the airway. would you be my assistant?
Absolutely.
Yeah. Okay, great. Just so that everyone gets a chance on the proper demos, I've already kind of made this vertical incision, but essentially your first incision will be through the skin, at which point you'll have somebody sort of retract the airway. Once you've sort of visualized the airway, again, very straightforward, you're making a vertical incision through 1 or 2 tracheal rings. One point I'll just mention is it is sometimes helpful to mark the midline. So I don't know if you guys know, when I do my intubations, I always have a marker, and I always make a mark across the neck. In this case, I would make a mark from the nose through the chin and down through the midline so that I have an idea, because as long as you stay in the midline, you'll be fine. It's vessels that are all on the side that you have to worry about, so if you're just in the midline, you shouldn't have any issue. That being said, I think having suction with this procedure is pretty important. So we like using the Ducanto suction catheter. That's the kind of the big one that sucks really well, as opposed to that little Yonker catheter, which isn't quite as good. So again, I've stabilized my airway, I've made my first incision through the skin, then my second incision through the airway, through the trachea, cutting through 1 to 2 tracheal rings, and then very similar to the adult procedure, we are placing our bougie through the airway.
Retracting the trachea as well, or?
No, it should be. This is floppy on my it doesn't need to go in far. That's the other point to this. It's not like an intubation where you're putting the tube in quite far. Essentially, you're sliding the tube in just so that the cuff is in the airway. So the cuff just needs to be in the airway, and inflate the cuff, and that's it. You don't want to go too deep with this. So again, we're going to just slide.
Came out the
port. This is our Seldinger technique. And you would normally lubricate this to be able to get this in a little bit more easily. Yeah, that's not good.
There we go.
Decapitate the kid.
No.
Complications of this procedure include.
Percentage of that.
Hopefully not that high. Parents wouldn't look at you very nicely.
And atlas occipital fracture.
I'll have to just leave it there because it was working a little bit better yesterday. The problem is this side is very soft now. It came pre-bent, but let's see if we can slip that through.
You want me to try and open up the trachea?
Go a little better now. I used a 2.5 tube at home. I think that's the other point is when you're looking at your bougie, your tube size on the Broslow tape, you want to go a size down. Again, on slightly better.
Could you also use that those sections that are like metal tubes and are very nice, and you like cover the hole and it does focal suction?
I don't think we have those. The teeny tiny,
They're like
skinny ones?
Yeah, or like they're metal and they're stiff, and so you can use them for like EMT stuff.
I don't know any metal ones.
We have the
These are the
pediatric
ones.
decantos
Yeah.
as well.
So these
And those are
are,
nice and stiff.
Yeah.
Yeah, this is the one that we use, the Ducanto suction catheter. Ducanto suction catheter is what I recommend. Sorry for the decapitation. But essentially, main thing to take home is vertical incision through 1 or 2 tracheal rings, slide in the bougie, slide in your tube, and that's sort of the way we're recommending to go with the surgical airways now for kids. We've got lots of models. Go ahead.
Blow the tube up. You inflate it.
Oh, I'm sorry. Yes, I don't have a syringe, but yes,
They do,
the cuff.
okay.
Essentially, slide the cuff just past,
Just
into the trachea, inflate, and you're
That's it.
done.
And would you So when you put in tracheostomies, like you can get like a fistula between, I don't remember, like the aorta or one of the arteries. Would you worry just because it's so small that you might like impinge on like the aorta or like one of the subclavians by inflating the balloon, or is that?
You shouldn't get the aorta or the subclavians, so they're kind of lower down. I mean, I suppose there's always a risk of a fistula, but you also have a kid with
Yeah, you just have to.
They've recommended just 1 or 2 tracheal rings to cut through because apparently beyond that it becomes more difficult to surgically repair the trachea after the fact. But with just 1 to 2 tracheal rings transected, apparently it's not that difficult to repair it. That does bring up a good just reminder again, which is that we're staying in the midline with these airways, not on the sides. So again, marking the airway, from the nose to the chin down through to the sternal notch, to remind yourself where to go.
And so, like landmarking, we're above, like.
It's not so much a feel thing as
Yeah.
it would be with an adult airway.
Yeah.
It's more just like visual. So again, that's why I would just mark with a marker and then just cut down. And have your. That's part of the reason I think we have a second person retracting, so we can actually visualize the airway, as opposed to classically where with adults we're feeling our cricothyroid membrane. It won't happen in a kid under 8 because their cricothyroid membrane is buried behind their thyroid cartilage, so you can't actually feel it.
So, but are we going above the thyroid or below the? Sorry.
You're going below the cricoid cartilage,
Okay.
and sort of above. I would say they recommend a
Okay, so lower.
Don't go at the sternal notch. So if you've got you want to stay away from the bottom quarter of the neck.
But would you cut through the thigh? Like I'm just thinking it's so small, right? So, and if you're not doing it by feel, right, then like, do you try to avoid the thyroid, or do you just go through the thyroid, or?
To be honest, I think it's a visual thing.
Okay, if
So
you see the
there
thyroid.
Essentially,
leave
yeah.
alone.
It's very much a visual procedure
Yeah.
from what all of the papers are saying. It's not a feel thing, and so
Okay.
stay away from the bottom quarter of the
Okay.
neck. But yeah, I mean, obviously you're going to have to see it, and if you see that the thyroid cartilage, you're going to have to go right below it. But it's a
Okay.
visual procedure.
Okay.